Okay, perfect. And if there's any questions, that you can tell me, because I can't see the chat. Awesome. Okay. So good morning, everyone. My presentation today is on evidence-based study methods for medicine. So I'm in my 4th year of residency, and I selected this topic on learning. So we know in the emergency department, learning can be very, very challenging, and we have a lot to learn and a lot of skills on day-to-day basis that we need to know. And we should always think about learning in emergency medicine as a journey and not a destination. So are you using evidence-based methods when it comes to your medical training? So we need to maximize our learning experience so we can become better doctors. And this is the outline of my presentation. So initially I'll talk about EBM, some learning myths, and then about practice and deliberate practice, and the 7 evidence-based study methods for medicine. So initially, evidence-based medicine started in the 1980s when Dr. Sackett, he introduced a hierarchy of advanced therapy. And then in 1992, Dr. Goyat and Sackett at McMaster, they came up with the concept of evidence-based medicine. Okay, so they basically had a group of physicians. They used literature in their clinical practice. So evidence-based medicine is the integration of research evidence, the best research evidence, with clinical expertise as well as patient values. So when you think about learning, it's there are many ways to think about it. The simplest way is learning is the process that teleported us from caves to where we are now. And when I was searching about learning, I found more than 20 definitions for learning. One of the definitions says that learning is a process which involves attention, storage, and retrieval of knowledge, skills, behaviors, and attitudes. And the definition that I liked the most was from this book, Make It Stick. And it's the definition used by psychologists, which says that learning is acquiring knowledge and skills and having them readily available from memory so you can make sense of future problems and opportunities. Okay, so basically you need to learn. In order to learn, you need to read, you need to be able to store the information and retrieve it later on. And that's known as learning science. And there are many ways to maximize the storage as well as retrieval of information. Okay. So when you think about learning, there are different learners, starting from a novice learner. So a novice learner is a person who doesn't know and does not want to know, and basically just a person who does not want to look dumb. Whereas a beginner is when you start solving problems. At the competent level, you start troubleshooting, okay? And proficient is when you can identify your own problems. So you have metacognition. So proficient normally can progress very fast. They have lots of skills and knowledge to share with the rest. And an expert is the person who doesn't follow rules. So it's the innovative stage. And they use analytical approach in new situations. A master is an expert who can teach. Okay. And why am I talking about learning today? Because most of the physicians are found to be at the level of at the competent level, and people from other fields, they stay at the beginner's level, and very few reach the expert level. So what we need to know that competent is not equal to excellence. So when you look at the path to excellence, it involves many things, starting from knowledge, skills, as well as thinking. And I'll start by talking about some learning theories that we have learned during med school. And can anyone tell me any of these, which of this learning styles is good and it has good evidence, evidence behind it? Anyone can answer.
Does the 10,000 hour rule, does it stand?
What is it?
The 10,000 hour
rule. Okay, you think it's good.
Yeah, maybe.
Oh, okay. Anything else?
I'm pretty sure there isn't good evidence for any of those.
Yeah. Okay. Good. So yeah. So there is no good evidence for any of these learning theories. Starting from the learning style, we were taught that some of us are more visual, some are auditory, but it turns out to be a myth. There's actually more than 70 learning styles, but there is no scientific evidence to show that there is a link between learning styles and successful learning, okay? And also being an adult learner is not different from being young. You can always learn and you can process the same amount of knowledge. And what about the right versus left brain? So some of us are more right side dominant compared to others are more left side dominant. So it comes to our learning and other skills. And this turns out not to be true. So neuroimaging data does not support this. And there was a study which was published in 2013 at the UK's Research and Skills Center, where they MRI'd people while performing tasks. And what they found that even when you're performing the simplest task, always both the brain hemispheres were involved. So that's not true. Okay. What about the learning pyramid? This was introduced in the 1940s and it was used in the training programs to help you know how much you will remember after 2 weeks. So for example, if you learn by reading, you will remember 10% of what you read in 2 weeks, while if you teach, you will remember 90% of what you taught after 2 weeks. And again, this is a myth. There's no any scientific evidence behind this. And even the numbers were never reproducible. Okay, next is what Mustafa said, the 10,000 hour rule. So we all think that practice makes perfect. And this was, this thing came up at 1993 when Andreas, like Dr. Ericsson, he studied a group of musicians. And what he found that the best musicians, by the age of 20, they have spent around 10,000 hours of deliberate practice, okay? And people started using the 10,000 hour rule. The best example would be this book, The Outliers, by Malcolm Gladwell, which talks about the magic number of greatness. And he says you just need to spend 10,000 hours of practice to be great in anything. And he used Bill Gates as an example and the Beatles as well, because they were practicing 2 hours every day. And but that's not true. What Ericsson mentioned was deliberate practice and not practice. And there is a big difference between the two things. So when you look at deliberate practice, you can see that you need to have 4 important things, starting from setting a specific goal, and you need to focus on it and practice it and receive immediate feedback on your performance. And you should always try to get out of your comfort zone. Okay, so I selected chest tube insertion as an example. So if you want to improve your chest tube insertion skills, you should select a micro skill. So for example, chest tube, I want to improve my suturing skill to be able to fix, for example, the chest tube. So my goal is to be fast and efficient when it comes to hand ties. Okay, so my focus will be to train as much as I can. I'm going to watch YouTube videos and practice, and I'm going to ask for an immediate feedback from a supervisor. And the exit from the comfort zone would be performing the technique under time pressure or use less suture thread to work with. Okay, so this is a practice, like an example for deliberate practice. And the problem is what Dr. Ericsson said, that like most of us have the same set of skills, like we learned over 1 year, and we keep repeating it over and over again, and that does not take us to the level of expertise. Okay, so this was the original study at 1993, and then it was again repeated and published in 2019, and it showed the same results. So with deliberate practice, you'll be better. Okay, and when it comes to medicine, I found this study in Journal of Internal Medicine. They used deliberate practice with simulation, and what they found that residents who were trained for ACLS using simulation with deliberate practice, they did much better than the second group. Okay, and when it comes to surgery, they're using it a lot. Like some institutes are trying to even, like the attendings are trying to videotape their procedures and share it with other staff to get their feedback. And there is this study on deliberate practice when it comes to laparoscopic surgery. And they took a group of senior residents. They taught them how to do lap chole using deliberate practice. And the other group was just the standard, received standard training. And what they found that the deliberate practice group had their quality of lap chole was much better. And their conclusion was that standard training may leave individuals in a state of arrested development compared with deliberate practice. Okay, and this is a more recent study. It was published in 2020 in cardiothoracic surgery, and they found that inexperienced residents can reach the performance level of fellows with deliberate practice. Okay. So what about using mental visualization, like to practice more? You can practice inside your head to count and to have more hours. So when Dr. Ericsson was asked in one of the interviews, he said only if your mental practice is correct, then you can count it as hours of training. But you will always need someone so you can verbalize to that person what you're thinking, so you can receive an immediate feedback. Okay. So remember, perfect practice makes perfect. Okay. And next is digital natives compared to digital immigrants. So there was an article published in 2001 saying that digital natives might be better when it comes to processing the high flow of digital content. And this is not true. Digital immigrants were found to be as good as the digital natives. So you can always learn through podcasts, social media, and everything the same way. So take-home message one would be that remember the path to excellence. Don't stop at the competent level, and only perfect practice makes perfect. Anyone has any questions?
Can I ask what is a digital immigrant? Sorry for my ignorance.
So people who were born before internet. Okay. So next is about the illusion of knowing. So we don't know what we don't know. This goes back to this curve. It's the Dunning-Kruger effect. It was introduced in 2000 by two American psychologists who studied competence and as well as confidence. It all started after they were inspired actually by a story of MacArthur, who did a daylight robbery. He went into multiple banks, and he was surprised when he was caught by police because he thought by applying lemon juice on his face, no one will be able to see him. And that's what inspired them, and they started studying the undergraduate students. So the first study, what they did is they tested undergrads by giving them different topics, and then they asked them to assess their own, what do they think about each of these topics, how confident were they. And what they found that students who were the novice learners who knew less, they were more confident than the ones who knew better. So always at the expert level, people think that their things are more complex, it's more complicated, and they have a lot more to learn, while the novice learner thinks that he knows everything. So, and this was studied also in medicine, where a group of physicians, residents, as well as medical students were challenged with clinical scenarios, and they were asked to match it with the diagnosis and then to rate their level of confidence. And what they found that residents were overconfident in 41% of cases, where their confidence and correctness was not aligned. And the faculty were overconfident in 36% of such cases, and students in 25%. Okay, and overconfidence can result in premature closure, confirmation bias, as well as failure to use the clinical guidelines. And that's why we should avoid falling into this curve. And when I was looking at FOMED, there was an old discussion where one of the medical education staff mentioned that in her experience, she finds that residents in their second year of residency are more likely to fall into this trap. Okay, so novice practitioners are at risk of falling into this trap, and it's always very important for you to challenge yourself and ask why, and always reflect with a coach. Okay, so when it comes to learning in emergency medicine, I found that in general there is like seven evidence-based study methods to learn medicine, but I'm going to talk about 4. So there is mental contrasting with implementation intention, which is also known as WOOP, and then interleaving, dual coding, spaced retrieval, spaced repetition, and rehearsal practice. Finally is optimization. So a goal without a plan is just a wish. So first I'm going to talk about mental contrasting, which is a new thing in cognitive psychology. It's all about self-regulated learning. So us as residents, we have the ability to create our own like learning plans and to decide on our own goals. And this might be the way by using this new method, which is also known as WOOP. So we all have like wishes and goals, but the main problem is that we don't identify our own obstacles. And the idea behind WOOP is you being able to identify your inner obstacle, not something else like from outside, not an extrinsic one. And you should have an immediate plan to act on it. So I'm going to give you a very, very simple example for WOOP. A girl, her name is Sarah. She's 5 years old. She moved to a new neighborhood. So her wish is to have friends. The outcome will be if she has more friends, she will attend more birthday parties. And now this is the challenge. She has to identify the obstacle, and it should be something from inside. So her obstacle is she's shy, and her plan is as following. So if she uses the school bus, she will sit next to another student and talk about her favorite snack. So she has a plan ready for that obstacle, okay? And this started by like a German researcher. Her name is Gabriella, and there is also a website for it. It's called Whoop My Life. There is a lot of research done, starting from health, like healthy lifestyle to medical education. Okay, and I found this like first time I read about WHOOP was from this. So it's from the Journal of Graduate Medical Education. And the title was that translating intentions into actions, a missing piece of the puzzle in improving resident self-regulated learning. So Gabriella tested WHOOP in like if it can improve the performance in school children, and it did. And in 2017, Dr. Daniel Sadawi, he's an anesthesia staff, he decided to study anesthesia residents during the ICU rotation to see if this WHOOP really works. And what he did, so first of all, he selected ICU because it's one of the busiest rotations. And during week 2 of ICU rotation, he divided the residents into 2 groups. One group received teaching on SMART goals. The second group learned everything about WHOOP, okay? And he followed them over like a duration of 3 weeks. And what he found, and he gave them a wish, okay? So the wish was that they should read more during this busy like rotation. So the WHOOP group were able to read 3 times more than compared to the SMART group. So the SMART group read a total of 1.5 hours, whereas the WHOOP group, they spent 4.5 hours reading on ICU topics, and 5.5 hours reading on anesthesia-related topics. Okay, so WHOOP definitely works. Okay, and it was tested also if it can help with stress regulation in healthcare providers, and it showed to be effective. So WOOP basically is all about self-regulated learning. So you should be able to identify your own obstacle and work on it. Okay. Next is ways to improve the retrieval of information. So the first way is spaced repetition. So we all study before the exam and then we tend to forget, but we should remember that we're studying for for our future as doctors, and we need to have that information available for us whenever we need it. So the spaced repetition is all about spacing your study. And first of all, I'll talk about the forgetting curve. So if you learn something new, within the next 30 minutes, you start forgetting. And over the next few days, you'll definitely forget it. So you need to space out things. So for example, if you have learned something new today in the emergency, you learned about a new antibiotic, you should go back home and read once about that antibiotic and then space it out, like read it next week and then the week after, in order to improve your memory and the retrieval strength. Okay, and what you can do, you can use the 10% rule, which says you can review materials at an interval equal to 10% of the time you need to retain it. So for example, myxedema coma, something we don't see that often. So if you learned about myxedema coma today and you want to remember it for the next 1 year, you should be able to review that topic once every month. And what was that? Okay. And spaced repetition was also tested, and what they found that students who used spaced repetition were able to outperform their colleagues by 67% with the same total study hours. Okay, and this was another randomized controlled trial, and it showed the same results. And so remember the forgetting curve and space out your study intervals. Okay. Next is interleaving. It's a very good way to improve your retrieval strength. It's by mixing topics. So instead of just reading cardiology and then neurology and then metabolic, what you can do is you can read one topic from cardiology, one topic from neurology, one from metabolic, okay? So this creates many beginnings and endings, and it's a very good way to remember things, especially for us as emergency physicians, as we move from one problem to another. So it will be easy for us to study this way. Or you can look at it as a problem. So if you think about chest pain, it can be secondary to many different systems. So it can be an MSK problem, rest, it can be a GI problem, or cardiac problem, okay? So try to mix topics together while studying, okay? And this was tested. What they did in this study is compare between math practice compared to interleaving teaching. So, and it was in students who were doing their radiology rotation. So a group of students received X-ray teaching based on interleaved method, and the second group was by math practice. And what they found that interleaved method of instruction led to better results than math method across all levels of education. And students who learned by interleaving, their performance was much better than math practice. Okay, and this was another study in surgery, the same thing. So basically you can learn by interleaving, and this will allow you to compare and contrast things, and the topics will stick better inside your head. Okay. Finally is retrieval practice. Learning always should be effortful, and you should struggle to remember answers, okay? And the best way is by using flashcards, and it's for everyone, not just for the R5. Anyone can start using flashcards. And one of the best studied flashcards is this one. It's known as Anki, because it's not just testing you, but they also use spaced repetition as well as interleaving. So topics are mixed. You can mix the topics, and it can also space it out for you. So it's one of the best flashcard applications out there if you want to download it. and it was studied in medical students who were doing their licensing exam. And what they found that students who used this app were like their performance was superior to compared to the other group of residents who did not use flashcards. Okay, and MCQs obviously, and always you can ask the staff to challenge you with questions during the shift. And so in order to strengthen the knowledge of retrieval, you can try distributed spaced repetition, interleave learning, or even retrieval practice. It's very, very useful. Okay. It's also important for us to know as emergency physicians about multimodal learning, which I'm sure most of you are using. It involves reading, listening, and like visual. So you're going to learn from Rosen, but you're also going to learn from your clinical experience, plus you listen to podcasts, and that will help you recognize challenging clinical patterns, and you'll be able to put things together. Okay, and you should remember that learning should always should have some degree of discomfort, and emotional activation plays a role in memory formation. So if your heart rate is slightly above 100, you're more likely to remember information that you learned during that time compared to when you're more relaxed. So I spoke about the learning theories, and WHOOP is very interesting and it's useful for self-regulated learning. We spoke about the ways to retrieve information, and I asked Dr. Nemes about his way when it comes to teaching residents. He said he likes to challenge and provoke them. He uses retrieval practice, but also uses other aspects. And when I asked Mahmoud, he sent me a very long audio, but anyhow, I summarized it. He says, learning as a resident is different from learning as a staff. He said, when you're a resident, you're privileged. You have a staff with you that you can learn from. So he mentioned Dr. Nemes as an example who would question him and put him on the spot, and he found that very, very useful, as well as Dr. Grad. And he says now that he is a staff, he has no one to challenge him, but he learned to learn from consultants. So he will always ask them why. And he listens a lot to podcasts. And he says getting involved in teaching is one of the best ways to learn. And he reads around the cases. And during handover, he says he learns a lot from the other staff. Okay, so remember to go the extra mile if you want to achieve excellence, and you should not stay at the competent level. Okay, some books for you to read. Rethinking Positive Thinking is all about WHOOP, and I would advise you to read that. And that's it for me. If anyone has any questions.
Thank you, Samya. There was just one question earlier when you talked about the study showing that so R2s were at the peak of dangerousness because of overconfidence. There's a question from Heather Coombs about how in that study they measured overconfidence.
So no, that was just a discussion from FOMED, and one of the medical education staff observation. She thinks that residents at the second year of residency, they pick up pace, they start seeing more patients, they feel more confident, and that's when mistakes happen. And they stop. She feels that at that stage, they don't realize that there is a lot of things that they do not know. So that's when they are most likely to fall into that curve.
Okay.
I have a question.
Yeah.
Based on the last four sort of strategies that you discussed, do you think that those strategies are something that residents should be learning about and implementing on individually, or do you think that you would use those to make changes to our current program structure?
I would say some are more related to program. So for example, mass practice. I think we learned every month to read in interactive, we cover one thing. I think we can maybe at the program level consider